with this said, we'll move on to the next point, and we'll go back to the checkpoint inhibitors. And we all kind of, theorize that maybe an anti-PD-1 is not enough. And interestingly, the data that currently either was reported or to be reported is not really but agreeing with this. And I'll start again with Tim, and tell us about pembrolizumab that was reported in the Keynote 240 not that long ago here in Chicago, actually. Tell us about pembrolizumab versus placebo in second-line therapy.
Well, so basically, after the initial attempts and demonstration of efficacy of immune checkpoint inhibitors using both pembrolizumab and nivolumab in smaller phase 1 studies, there were phase 3 studies conducted to look at this in a randomized controlled fashion against placebo. And basically what this study shows, and this is, it turned out for statistical reasons to be a negative study. If you look at the individual endpoints of survival and PFS, it was actually positive, but we have to mention that, the way the study was designed, it is a negative study. Now, if you talk to the patient and show them the data, it's very hard to argue against the drug.
Fair. Mike, we're hearing this, and this is public. Already there was a press release that the checkpoint 459 of nivolumab versus sorafenib is also negative. It's going to be reported hopefully in a week time. But again, do you see this point that Tim is bringing up, maybe the design, or it really doesn't work?
I think clearly these are design questions. As the field has evolved, there's been attempts to create combined endpoints and to, certainly attempts to decrease the size of some of the studies. And I think that's really led to the results we've seen. I think we all have seen remarkable results with immune therapy, patients that have complete responses and so on. So they clearly work. The response rates are very similar. Well, we don't know about checkmate 459 yet, but at least in Keynote 240 are very similar to the response rates that were reported in prior studies like Keynote 224. So the drug clearly has consistent activity.
No, I hear your point. If anything, clearly it could be a design question, but I think there's more to that, because remember, the aspired for improvement in outcome was really kind of considered to be is going to be overwhelming. Mm-hmm. And if it didn't really cut it, and especially in first or in second line, it's telling us again, maybe what we just spoke about in the first or the beginning of the program today is that maybe anti-PD-1 is not enough by itself, and maybe an anti-CTLA-4 kind of combination therapy might actually be the one to break it. And interestingly, it brings in, of course, the potential for other combinations, which is the anti-angiogenics as well. And so with this said, we're hearing about several combinations at the moment. We already spoke about one, which is Durva plus Tremi, the Himalaya study, and we're waiting for the data on that one. But beside that, tell us about the other combinations, maybe, Tim, you can tell us about the pembro-lenvatinib.
Yes, this concept of combining different mechanisms, may it be just the vascular targeting component of lenvatinib or others, we mentioned AXL or other mechanisms, some of them we probably don't even understand, seems to be very attractive because, as you just said, we have to be realistic. A response rate in the range of 17, somewhere between 15 and 20% that we see with the checkpoint inhibitors as a single agent are nice. If we treat these patients, it's long lasting, it's good, but obviously, it is way too low because what we don't see is that 80% actually do not show this response rate. So we combine this, and that's very interesting. And we see now in this very early data that we have so far, a significant increase in the response rate. The problem we have at this point is we don't know necessarily that response rate translates into overall survival. Obviously, from small studies, we usually look at this, and that is basically what time will tell us. But the approach of combining TKIs or targeting mainly using as a vascular targeting agent together with checkpoint inhibitors is very attractive.
Catherine, back to you. So there is also another combination that we are hearing quite a bit about, and I would like to bring up two trials over here and maybe try to at least dissect them a little bit further. The atezo plus bev was a anti-angiogenic, and also there is an atezo plus cabo as well. Your thoughts?
Right. The combination trials, I think, are all what we're all very excited about. And I think we will end up with better response rates, which hopefully will translate into the better overall survival. You know, combining the atezo with a VEGF or the atezo with cabo, which, as we said, does have immune system effects as well, will be very interesting to see if we can improve that survival as we've seen. We have to remember, of course, the toxicity of the combinations, which is something that I always worry about and discuss with my patients. You know, the more drugs you add, the more toxicity you may be at risk for. It's also very interesting to see the combinations that were used, say, prior to like neoadjuvant and then adjuvant with resection and the high response rates that we're seeing pathologically. And it would be great if we could figure out how to tell which patients are going to have that response and perhaps not have to go through a major surgery because they've had such a great response.